to have. It took me a little while to get back into this space. I left for a while. I went and had some other careers, but after I'd gone to treatment and had an experience with insurance not paying, and it started to pique my interest. And I was sitting with some people one night and somebody said, "What do you want to do?" And I had my securities license. I thought I would just go back up north and go to work back with the company I was running. And I said, I'd like to do something I believe in as much as I did when I worked for Anheuser-Busch. Because as a 23-year-old college graduate, I loved my job. And, I had jobs after that. And the next day, somebody called me and told me about a marketing job with the Hazelden Foundation. And I got that job, and the rest is kind of history. I met a guy named John Southworth who opened up doors for me that I can just, there's not enough time in this hour to, or whatever it is, to talk about it. But I really wish I was at my home office today, because behind me on the wall would be that picture of John that we got when he died, saying never give up. It's just a pleasure for me to be here today and to be with you guys at Southworth Associates. And I'll share whatever I can about the space, about how I got into it, but it was really a God thing. I didn't plan this. I looked at maybe being a counselor first. I got in on the marketing side, wound up going back to school, getting a master's in substance abuse counseling, and it's been an interesting ride.
Yeah, it's interesting the longer that I'm in this and talk to more and more people, to see the effect that John had on people, and how welcome he definitely welcomed me into this industry. I'd been working for about a week and got a chance to meet him, and we had a meeting before we started the event that day, and I was like, this is just amazing that we get to do this. And he said, yeah, this is what we do. He had such a positive effect. But also along that line, there's so many people that have gone and done this for a long period of time, so many mentors and people to look up to. So like, who are some of your mentors and people that you did kind of get into this field with and walk you through it?
Well, I feel really blessed, Glenn. I got in it at a time, it was kind of the salad days. If you're familiar with, some of the younger people remember Raising Arizona. Yep. The movie, it was a great time to come into the field. Most people were, thank you, Cindy. Most people were coming into this with no intention of making money. It was all about helping people. I mean, it's America, but there wasn't a lot of money in the treatment business then. It was after the crash of the 80s and before the salad days in the 2000s. But in the late 90s, it was a calling. It was a mission. And people get into this not for the salary, they get in it. And there were so many people. It started at Hazelden when I was in treatment, and I started to learn the history. And I told you, my first mentors were really the people that have been doing this a while. I became an alumni speaker, and I started to meet some of the counselors. And there was a former priest from Ireland named Jerry Singleton who gave me the best advice ever. He was my first boss. Actually, he was my boss's boss. And back then you had to have 2 years before you could start doing anything. And I was a week shy of 2 years when I got that first job, and I started a week later, and he said, "What are you doing, Walsh? Congratulations." And I said, I work for you. And he said, "Yeah, in your words, what do you do?" And I said, "Well, I work in recovery." And he said, "No." And he paused, and Jerry was just an old, great Irish man. And he'd been sober a long time. And he looked at me, he said, "You work in the disease." And I'm not talking about the patients. Yeah. So you need to go to twice as many meetings. You need to get a therapist if you don't have one, get a good sponsor, and take care of yourself. And that was some of the best advice I ever had. There was a lot of doctors I wound up learning from. I was a woman, Dr. Barbara Krantz, who some people might know. She runs Karen's Ocean Drive program. Got sober in 1981, triple board certified physician with a master's in nuclear medicine. And Mrs. Delaney from Alina Lodge, and Father Martin, and Bill White, and so many people up at Hazelden, and this guy Mike Early, Dr. Lynn Hankus. I mean, people that had been around a long time. They've been doing the kind of like in in personal recovery, looking for those mentors and those people that had come before, and learning the history, and just trying to soak up whatever I could. I was like a puppy dog. I followed them around at conferences. And as you and I talked about, I walked in, my first speaker at a conference, I heard Bill White talk. And for those of you out there that may not know Bill White, or the Bill White Papers, his blog, or Slaying the Dragon, which is a fantastic book on the history of this industry going back to the 1700s. And a lot of people don't know it went back that far. All the attempts at trying to help out addicts and alcoholics over, centuries. So those are the people I still look up to today. A lot of them have passed on, but I still hear their voices. And if you're new in this industry, look around and find people that are doing cool stuff that you're interested in. I don't want to get on too much of a soapbox, but I think, we'll talk a little bit about my thoughts on the changes. And not that you shouldn't get in this and make money. I mean, this is America. A guy said to me years ago, why can't we help people and make money? And I've found that it's really easy to do one or the other. It takes a lot of work to do both. And that's my goal, is to try to help people figure out how they can do both. How can you make a decent living, make some money? This is a capitalistic society, but how can we help as many people as possible? I mean, there's so many people out there that need our help. And how can we figure out to touch more lives?
Yeah, I do. Oftentimes I find that we run into people that are either, focused on one or the other. I was talking with another professional yesterday about the benefits of an active alumni program. And it needs to encompass both, right? Like you really, in order to have a quality program, you have to be able to keep the doors open. But if you just focus on the money side, you lose the human aspect of it. And so I think it's such an important message. And I will tell you, most of the people that I look up to in this field and in this industry have both of those perspectives. They know we need to be financially viable, but it really is about helping others.
Yep. And if we can do both, we can help more people. It's just, it's not rocket science.
Absolutely. So, and I'm a big fan of Bill White and Slaying the Dragon, and did my research and to understand kind of where we came from, and especially with the way that we tend to reset in this industry. What are some of the things that you've seen over the years that whether it's be a reset or something new that's come out that maybe people out there should know about, so we don't reinvent the same thing or make the same mistakes?
Well, and one of the things that I've come to learn is that, there are some great modalities out there, but there's no substitution for time. Whether someone walks into a 12-step meeting somewhere in the world, in a church basement or whatever, or into a church, or however you're going to do this thing to change your life, I think the most important thing to start with is you didn't get to the point where you're ready to accept help and ask for help and all of that, crash and burn, however you got here, overnight. And you're not going to get out of this thing overnight. So although I do believe that we have made great advances in cognitive behavioral therapies and, trauma-based, evidence-based practices, medicine, a lot of different things that can help, I don't think in and of themselves any one of those is going to do much unless you give yourself the time. Some people are ready to do a deep dive earlier on than others. Some people aren't cognitively aware enough to take a look deep down until they've, got a prolonged detox. That post-acute withdrawal can go on for a long time in some cases today. The drugs have gotten so much more readily available. The brain chemistry changes. So again, there's no flipping a light switch and getting this thing. The good news is there's so many avenues. There's so many modalities. There's so many great clinicians out there. I hope we continue to learn and evolve and not just think that we've got the solution. If you think one thing is the solution, read Slaying the Dragon, read about the Keeley cure back at the early 1920s or 30s. And, they popped up all over the country and they were gone in no time. Because it wasn't the solution. It was the fad. It was a Post-it note. It was a tweet. It didn't last. So what we want to do is build on what came before us in the best way we can to give people as many avenues as possible to One of the things I get asked a lot as an interventionist is, what's the success rate? And I always ask them back the same question: what's your idea of success?
Yeah.
Is it completing treatment? Is it, getting a year? Is it, some people want their son and daughter to stop getting arrested. Others want abstinence and a spiritual awakening. And there's a whole bunch of territory between those two. So first, we've got to figure out what's the goals and objectives of the family, of the client, and how can we as a treatment center or treatment professionals help them get to that goal. And if their goals are maybe short-sighted in our opinion, based on what we know, how do we get them to kind of open their eyes to more possibilities and go after more? I think we shoot our wounded too often in this industry, whether it's somebody who's relapsed during treatment or somebody who's been clean and sober a while, maybe even working in the industry and has a relapse. What do we do to kind of get them back on track, to encourage them to go a little deeper dive? That's probably the thing I've learned that's helped me the most, and that I would like to get across to whoever's listening. It's kind of like using, they say you can get off that elevator whenever you want. You don't have to go to the bottom and die. On the other hand, you can take that elevator ride as high as you want. I heard early on that you're never staying still. You're either getting better or worse. So, I've had that experience, and you probably have too. The more work I do, the more benefit I get. The longer I continue to work on myself, the more I'll evolve. So
Yeah,
find some mentors and do that.
The time thing that you mentioned is so important. When I used to coach, and inevitably somebody would come up and say, Glenn, how long is it going to take me to get this thing? Like, how long until I'm going to get there, right? And I always tell them, it's a million tennis balls, right? Because I was a tennis coach. It's a million balls. You can get there as fast or as slow as you want, right? But it's going to take about that time. And as a coach or a mentor or a professional, it's really my job to keep the person engaged until they get to that million balls. And so in our field here in substance use treatment, we really have so many different great modalities out there that help to keep the client engaged long enough for them to start using the tools in recovery, to start using and making different decisions, and relying on different coping mechanisms, and I think that's a really important point. So let's see, what over the years, talking about recovery fellowships and the treatment industry and kind of the relationship that they have, what have you seen? Has that relationship grown together? Has it kind of fallen apart? I know we need to have both. It needs to walk hand in hand. What has been your perspective on it?
My perspective on it is we've changed a lot. And I remember talking to a guy years ago who had a lot more experience than I did. And he said, we don't do in personal recovery today what we did when he came in. And when he came in, they literally detox people in their homes, on their couches and things like that. And thankfully, we don't have to do that in most cases today. We've got medical facilities, we've got treatment facilities. So that evolution has been fantastic. On the other hand, some people don't think we do as much 12-step work in personal recovery. And I'm trying to be careful as I choose my words here, because part of this is, treatment is different than personal recovery. And I personally like to keep that line as clear as possible. Again, as Father Singleton said years ago, working here is not your recovery. If you're in recovery, I want you to keep that totally separate. However, what I've learned is to try to use those same principles of recovery in my professional life. So to keep my side of the street clean and all that. What I've seen, and part of it has been the advent of the internet, is that some of the traditions of 12-step recovery groups have been bent, twisted, turned upside down. The lines aren't quite as clear as they used to be. There was, you would go away to treatment and then you would be discharged. And then there was this whole other personal recovery thing. And now we've got so many people that are in both. And we've got so many people that are on the internet and Facebook Live and all of this, that I've tried to keep my hands in both pies so that I can respect the traditions personally, but also talk as a professional about recovery. Part of that is, not identifying. I heard early on, you don't identify yourself as a member of a 12-step group, but you can talk about the fact that you went to treatment and you don't drink and drug anymore. I mean, those are some of the areas where I think that we need to educate people more, because it's really easy to blur those lines. How do I know when I'm helping and hurting? And one of the important things Bill White said to me one day recently is, when you have something to say, try to make it about the message and not the messenger. And I thought that was so profound, because as human beings, it makes us feel good to be the guy or the woman out there, doing the good stuff. But I think sometimes our message gets lost when it becomes more about us than it does about the message. So, it's a constant battle for me as I try to educate more people and be more public about treatment and recovery, to keep those things totally separate from a personal standpoint. Does that make sense?
Absolutely, and we need both, right? Both of them address two separate sides of the coin, and we really do need both to walk hand in hand. I think it's been a fascinating relationship over the years, and especially now with the advent of so many people on social media and stuff like that. I think that we do need to educate people on both sides of that coin, how to kind of work together and operate,
And again, they are two totally separate things. Treatment is not a 12-step recovery program, and treatment shouldn't include just 12 steps, because we do have some people that are averse to that. I've opened my mind to that a lot. Medication-assisted therapy, it's not one or the other. I mean, I was involved a few years ago with some physicians who started this group called the Like-Minded Docs, because we had like the medication-assisted therapy and we had the 12-step, and both, I think, didn't know enough about each other. And the 12 steps were fighting, it was kind of like what's going on in politics today. And there was a lot more of a meeting of the minds in the middle. But we had to have that conversation and open it up. And what these docs started talking about was the sensible use of medication, rather than a one size fits all for everyone. We've also got all these young people coming into treatment now that maybe didn't get to where people did 20, 30, 40, 50 years ago when they wound up at a self-help group or a treatment center or a hospital. So are we treating them differently based on what their needs are, what their history is? And that's where I'd like to talk a little bit about today is the assessment process and how we actually recommend different facilities. And how many facilities does a clinician actually know about? Because there's so many different shapes and sizes that, like snowflakes. And if you don't educate yourself to what's available out there, you may wind up sending everybody to the same place. It was one of the things I learned from Southworth is that, I was blessed to go see hundreds and hundreds of programs from, the Salvation Army to the high-end places in Switzerland and Malibu that, are for the 1%. And there's a whole bunch of stuff in between. So I really think it's important to share information, to find good mentors, to continue to evolve, because we've got so many people that need our help. And if we're not putting them in the right places, they're more likely to get a bad experience and not come back when they desperately need to.
Because there's so many.
I'll end with this. When I got in my first admissions job, there were 264 questions, I think, before we got to money. Biological, psychological, social. It was a pretty thorough assessment before we started to talk about whether this was the place for you. And in a lot of cases today, I hear 2 or 3 questions, which really isn't a good assessment.
Yeah, and I've for lack of experience when I got into this deal, and like many others that come in through a personal recovery story and they get into the field of substance use treatment, we have a singular view of what a person suffering from alcoholism or drug addiction looks like, and it's based on our own experience, right? And so what I've seen is that people will tend to gravitate towards what worked for them, and instead of looking out and seeing we are so drastically different, and there's different modalities and therapies and treatment plans that work for a particular person. And I think that that's one of the challenges that we run into today with our carriers, with the insurance, the payers, because we're trying to explain to them that what we do works, and it works for a certain type of person, right? But it may not work for somebody else. And so it's really caused I mean, you know, we all see it. It's caused a very combative relationship between payer and provider. And so to segue from that into like your time as the president of NATAP, and you were at the forefront of that, what were some of the things that you saw during your time serving there that that maybe addressed some of the payer provider relationship or some of the other policy stuff?
Yeah, well, and again, starting before NATAP, you know, I learned the history of what happened in the 80s. You know, I have a lot of mentors that were around then, and you know, this boom isn't the first time it happened. And you and I have talked about this, and you know, crashed and burned, and you know, literally almost overnight, about over 60% of the beds in the country closed because people started to get into this for the wrong reasons, in my opinion. People started to make a lot of money, a lot of fraud and abuse came around, and all of a sudden they were like, the payers were like, we're done, we're out, and it devastated the industry. And we started to see some of that in 2008 before I took over NATAP with the Affordable Care Act. I mean, a lot of us that were working in the private pay section, and again, I don't want to discount, you know, the Council on Behavioral Health and a lot of these state-run Salvation, you know, so many programs that weren't part of NATAP. We were more the private pay and the insurance programs, but, you know, there was some other groups out there. So there's a lot of different types of treatment. But what happened was similar. All of a sudden we were like, please, I wish insurance would pay. I wish insurance would pay. And then it was Pandora's box, because all of a sudden the Affordable Care Act made it more accessible for people that were dependent on insurance to go to nicer places. And then all these places started popping up, and people with less experience, in my opinion, started opening up places, many with good intentions. But again, you don't know what you don't know. And I look back now, I thank God that I came in when I did, because if I'd come in later, I probably would have opened up a place and I didn't know what I didn't know. Right. Now, I'm still learning today. But at the same time, and I wish Dave Curtis was on with us because he can tell you more exactly, but the drug testing piece came in, and that messed up a lot. That was right before I took over NATAP, where my understanding of it is, and I remember reading an article in Vermont or Maine, they were testing senior citizens in nursing homes for PCP and all kinds of drugs 7 days a week and charging a lot of money for those drug tests, not because they needed it, but because they could get paid for it. And they got slammed for fraud and lost a ton of money and a lot of business. And all of a sudden they started going, where can we make up that business, that market share? Who does drug testing? The treatment industry does drug testing. And they started to show us in the treatment industry how we could do this ourselves. And people started to go, oh man, if I do the drug testing, I can make more money. I can help more people. And other people just said, man, if I get into that, I can make a fortune because I can do my own lab and a treatment center and refer to myself. It blew up. So fast forward to NATAP, I was lucky enough to get called. Somebody asked me to apply for the job, and it was at a tough time in our industry. A lot of stuff was going on, and I really thought I was going to come in on like a white knight on a horse and clean up this thing and fix it and go to Washington, and everybody was going to rally behind me, and we were going to just revolutionize the industry and band with all the other associations and help everybody in America and around the world. And a couple of years later, I felt a little like John Belushi in Animal House, running out of the frat house thinking they were all following me and realizing nobody was there. Because it's a big job. And if you watch the news today, you see how difficult politics are. And unfortunately, part of our field is tied up in politics. I today have come from trying to do a little more closer to home. I'm very involved still in Florida with some of the advances we've made. Florida became kind of ground zero for fraud and abuse and bad treatment after being, you know, the treatment haven and destiny for so long. And we're not perfect there, but we've cleaned it up a lot. And I'm living out in Arizona now, and I'm trying to help some people here that are trying to get out in front of this thing. And as I travel around the country, it's one of the things I love to do is to talk about my experience in Florida as this thing mushroomed and blew out of control, and maybe start to figure out some solutions so it doesn't have to get that bad.
Yeah, because, you know, one of the...
Marvin's got his hands full. There's a lot of personalities. There's a lot of self-interest. Again, it's a lot like politics in general. So,
yeah, so... Yeah, it's an interesting thing that when you look at the history of how we've evolved in this field, and you see, like, you know, like you said, in the 80s, people saw the ability to take the length of stay guidelines and really, you know, bill out for that and try to, you know, make a lot of money doing that. And then that got reset. And then we had the drug testing thing, same thing. And it just goes to show that in our field, there's nothing wrong with making a living, but it really does have to, I mean, it's a labor of love that you have to be in this for the right reason. Because
and there's nothing wrong with drug testing, by the way. I mean,
absolutely.
Transportation, physicians, attorneys, pilots. I mean, in the general public too. I mean, one of the things Southworth always harped on is that, you know, the physician's outcome study. And if you don't know that and you're in this industry, look it up. It was published in JAMA, I think July of, I want to say 06, 05, 06, something like that, where they followed all these docs and they had phenomenal success rates. And the reason they did is because, and they knew it, and we can say what the success rates were because they drug tested them.
Right.
It's really hard to get outcome studies if you're not drug testing. Those of us that have done it, you know, if you're doing self-reporting, it's hard. We do have more support for that now. Some of the big payers are getting behind outcomes and following people. But I look at it, and I'll use this analogy. I'll try to make it quick. I went to the doctor for high cholesterol years ago. And, you know, I treated it like a New Year's resolution. I was in his office. I said, I'm going to do this. I'm going to get it down. And I left and, you know, went to the gym, threw out the Ben & Jerry's. And 6 months later, my cholesterol hadn't changed at all. And, you know, people do New Year's resolutions all the time, and they start out, and then 2 weeks later, it's like back to the same old. And that's what happens in recovery a lot. We go to a doctor, we go to a therapist, we go to a treatment center, we get a discharge summary, we get a discharge plan, and most people don't follow through with it. And when you've got attorneys and pilots and licensed professionals, and you can say, if you don't follow this plan, you don't get to do what you want to do. People are more likely to do it, and they have really good outcomes. And I remember, just to finish up the cholesterol, it took 2 years. I had 4 different, every 6 months, I had my blood work done until I was finally done. And my doctor said, I'm going to write a prescription. I said, give me 6 months. 6 months later, it was down over 100 points. And I walked into his office and he said, oh my God, what did you do? And I said, I did what you told me to do 3 years ago. Not got any smarter. You know, the plan hadn't changed. I had just executed the plan. And I think that's what I like to focus on, no matter what your level of care, no matter what your treatment program is. You educate people, and then you help them figure out how they're going to follow the plan when they leave, because that's where recovery happens. And, you know, touching on that, the industry piece, Florida model got a bad rap for a long time. The Florida model's fine for certain people. Right. It's what people did to the Florida model. You know, residential programs can be great, and they can be terrible. Medication-assisted programs can be great. They can be terrible. Clinicians can be great. They can be terrible. So I like to look more at what is that person or place doing, and are they doing the things they say they're doing? Is there truth in advertising? Are they trying to continually do a better job? Or they put up a really nice website, whether it's a clinician, a therapy group, you know, again, a treatment center, and talk about all these wonderful things that they don't actually do.
Right on.
And, you know, part of what you and I think we're going to get to is the laws. And that's where a lot of our laws are unfortunately going today. And I want to encourage you again, if you're in this industry, get involved locally. Trying to change it nationally, it's too big. But if you can get involved with, you know, public policy, and if you don't know who Carol McDade is, Capital Decisions, look her up. And Carol does a lot in DC, but she's also helped people do things in their states and in their towns. And if you are in this thing and you're complaining about the state of things, find out who's doing what and get involved, because there's a lot we can do. Somebody said at NATAP at the board meeting years ago, and it made a lot of sense, that if we didn't get involved in this thing and start to take control of the narrative and help plan what the laws are going to be and what people were going to pay for and what they would have access to, then politicians were going to sit in a room and make those decisions, and they don't have the information we have. So I don't care if you're about needle exchanges, Narcan, treatment, therapy, licensing, whatever it is, get involved locally. That's the only way we're going to change this thing.
Yeah, because one thing that I know from talking to different representatives and community leaders is that, we are one of many things that they're working on, and they just can't be the experts. They're not supposed to. They need us to communicate with them on what is pertinent. We, for example, I know that there was a representative that was speaking on our behalf, and this has been a couple of years ago, but speaking on behalf of the industry, but didn't really understand the difference between PHP level of care and sober living.
Yeah.
And that's really important. We know that in the field, but we need to educate them and advocate locally, so our local representatives can keep going up the food chain. I agree 100%.
I remember sitting with a gentleman in Florida who was a politician and was charged with finding out what was wrong in the treatment industry. And he was sitting next to me at a luncheon, and he leaned over and said, "What's the difference between a halfway house and a treatment center?" And I thought, man, we have a lot of education to do before he's going to be able to help us. So it's on us if we want to make changes to get in there and try to help be part of the solution.
Absolutely. I love that. So to get in, like, is there any policy stuff that we need to be aware of right now? And then I want to get into a little bit of how to get into this deal, but like, is there anything that we really need to be looking at right now?
So some of the things that, again, to me are important are, there is a lot of legislation. There are a lot of pharmaceutical companies and different things coming in. And again, I used to be against medication-assisted therapy, and I am not. I'm a fan of it for certain people. But again, I like the sensible use of medication. We can't just put everybody on a pill or a shot and think that all of the issues that caused them to use in the first place are going to go away. So making sure that we keep to the research, evidence-based practices. And, what I've read about medication-assisted therapy is it's great in conjunction with counseling, and when you're not drinking and using other drugs and all these things. And again, I think there's some great medication-assisted therapy places out there. But like the abstinence-based programs, there's a lot of programs that could be doing it better. So those things are happening because there's a lot of lobbying going on in DC. And again, there's a lot of money involved when you're talking about new pharmaceutical modalities. There's a lot of money at stake. So they've got the lobbying arms that we don't have, and the voices sometimes we don't have. So again, I'm not against it, but let's make sure we're in the room so that we can do it sensibly and we can do it for those people. Because I remember being in an ASAM meeting years ago, and one of the docs looked at one of our recovery docs and said, if you're not providing medication-assisted therapy, you're committing malpractice. And the doc turned around, looked at his colleague and said, okay, I'm going to give you that. But if you're not also offering abstinence as an alternative, you're also committing malpractice. So it shouldn't be either or. We should be working together. And for some people, medication is going to be the best way to go. And for other people, abstinence is going to be the better way to go. So we've got to get involved and educate. So that's one thing. The patient brokering laws, they're getting written in states all over the country. And I read some legislation a year or so ago in California by very well-intentioned people that didn't see, as Paul Harvey used to say, the rest of the story. So, they sit in these rooms and they come up with these bills that to them sound really good. And then we look at it and go, but you're not thinking about this. So the unintended consequences of laws many times, one of them that I'm dealing with right now, I heard about in Oklahoma last week, and I think this is another big one around the country, is 2 years ago, I believe it was passed that if you're in prison that, you need 30 days of treatment before you get out, but they're starting to treat people right before they get out of prison. So like if you're in for 5 years, you're in for 4 years and 11 months, and then your last 30 days you're doing treatment. So now you're raw and real new to recovery, and you're not only dealing with getting released from prison, which is hard to reentry, but now you're early in sobriety possibly. I know nobody thinks there's drugs or alcohol in prison, but there are. So why don't we, that's a great thing to do. Like, that's a great law they passed. But if I was in that room, I would have said, why don't we treat them for 30 days when they get into prison? Maybe they'll have 5 years of recovery before they get out if they're on a 5-year sentence. So that's one that I would encourage people to look at. The involuntary commitments are starting to get talked about again. If you're not familiar with the Marchman Act in Florida or Casey's Law, Kentucky 222, look those up. As an interventionist, again, there's a lot of states where I can't help somebody who's clearly, to me, a danger to themselves or others because they don't fit the criteria under the law in many states for anything more than 48, 72 hours. In Kentucky and in Florida, you've got the ability, if someone's really that bad, you can do longer than that. And I'd encourage people to get involved. I'm working with a couple of lawyers in a couple of different states right now and some politicians trying to help get the involuntary commitment looked at again, because I did a master's and I wrote on this in 2006 or 7, and there were, I think, 14 states considering legislation back then, and only one of them has passed it since then. So that's a piece that I would ask people to look at. Massachusetts has passed that 14 days. That's a good start, but I think 14 days is a Band-Aid on a hemorrhage. But again, this is a huge issue all over the country. And educate yourself. Learn how much we save as a society by helping people get back on track. That's when all's said and done, a lot of this comes down to making a financial argument for providing good care. And, we've been able to do it in the workplace. We have some great figures now on how much it costs to send an employee to treatment and then bring them back, as opposed to firing that person or letting that person go and then have to find another person to replace them. And what does that cost? And retrain that person. And what does that cost? And how long are they going to be there before they get up to the caliber that employee we had to let go is? So the cost benefit analysis for companies is out there now. I mean, we're getting a lot more EAPs back in the mix. We had lost that business for a long time and people weren't getting well. So that's another issue that I think we really need to look at.
Right on. So whether I'm, talking to some of the audience members that are wanting to get involved, how would you say is the best way to get involved, either in the public realm and public policy realm, or if they're looking to get into the field of substance use treatment? Like, what are some of the best avenues and ways that you would recommend for them to do that?
Yeah, I'm a big networker. Again, I moved out here to Arizona, and the first thing I did is I got on Facebook and joined the Arizona Health Professionals page so I could start asking questions about who's doing what. And I went out and met some of the reps from the different treatment centers out here. I did already know some people, so I had a head start. But, one person would tell me about this other person who's doing this. And rather than going in and trying to reinvent the wheel, go in, see what's already being done. Southworth used to always say, find a hole and fill it. If somebody's doing something that you're really interested in, ask them if you can help. If you go in and you say, what's being done, and you find out that all this stuff's got some people helping out there, and maybe I can go over here and kind of fill this gap that's not being done. Also get on some of these networking sites and find out what they're doing in other states. I mean, that's one of the things I was able to do here, was come in and say, look, we went through this in Florida 8 years ago, where you are now. And these are some of the things that we did there that would be beneficial. So it's really about networking. The advocacy is great, but you've got to be able to find out if someone's already doing what you're talking about, why reinvent that? Why don't you join forces with them? Now you're twice as big. But again, I think by asking people who've been doing it, finding out what's already being done, finding out what your passion is, and that to me is a blueprint, if you will, for whatever you want to do in this business. If it's a job, if it's going back to school, if it's starting your own place. A lot of people out there have done it. They've learned the good, bad, and the ugly. They've had experiences. So find people and ask them. Most people in this industry will help.
Right. Absolutely. That's what I find. So to kind of wrap things up, I did want to ask you before we have to close, I wanted to say, like, what are you up to today? Like, you mentioned a little bit about it, but like, what are you doing today?
So my passion's always been intervention since John made me do my first one, but I'm not doing that many of them today. I do have a lot of friends that are very qualified that you've had a couple of them on the show. And I'm giving a lot of those to my friends these days. When I get calls, I'll do them because I love doing them. But I recently, I've been helping for about a year and a half with a high-end sober living in Brooklyn called Williamsburg House. That's Benji Fleischer, for some of you guys that know him, he's a great guy, and they've got a cool program there. It's not for everybody, but it's a absolutely wonderful long-term sober living, kind of high-end in Brooklyn, which is a really cool place to get sober, especially if you're young. And a couple of months ago, my stepson started a company in 2015 called Landmark Recovery. And I've been an unpaid consultant since he was about 8 years old. And during the last couple of months, I've come on as they grow. And they're, in network, small markets. And he also has a company called Praxis, which is Medicare, Medicaid. I mean, trying to fill that other part of the industry that I haven't worked a lot in, which is the local, trying to provide evidence-based, good, solid local treatment for people who either don't want to leave home or can't leave home. And again, we didn't even get into that whole should I stay or should I go piece, which I love talking about. And I think that destination recovery was the thing for a long time. And I think for some people, that's still a great option. But for other people, if you're going to get clean and sober and work and live where you are, why not look into doing that there so you don't have to start again after you get out of treatment? You've got that cohort group that already lives there and all that. So there's benefits to both. I don't think there's any one way to do this thing, but I do believe in Matthew's vision, which is to provide solid, evidence-based local treatment in small markets around the country for people who either can't leave home or don't want to leave home. So I love doing this. I'm very proud of him for what he's done. And again, the Medicare, Medicaid piece, not nearly enough beds in that space. And that's part of his mission as well. So,
right on. So let me ask you this, because I want, normally I have people that ask questions and would like to get in touch with you. What's the best way to get in touch with you? Can you let our audience know my
cell phone is the best way, 561-346-2005. mwinterventions.com is my website. If I'm available, I'll pick up. I'll talk to anybody, anytime who's trying to help people. I don't care if you're looking for a Salvation Army bed or the most expensive bed in the world, which I believe is still in Switzerland. If I've got contacts that I can share with you, I'm happy to do that. There's another thing John and some other people taught me is there's way more people out there that need our help than there are beds available. So work together. Find people that are doing good, solid work and share that information, because we're the ones that need to gather the information and share it with the general public. When I got in before the internet, it made me cringe when people in treatment would look up nothing against SAMHSA, but they'd open the SAMHSA book and pick a number or a program out of a hat with no idea what they provided for services. And today people get on the internet and, I got quoted years ago saying people spend more time picking out a pair of shoes or a handbag than they do a treatment center or a therapist. And we need to be available. We need to do our homework. We need to know who the good providers are. And we need to share that information. So I would encourage you all to do that. And if I can help, give me a call anytime. I'm an open book. And again, if you got into this industry to help people, take care of yourself. Remember that this is a marathon, not a sprint. We don't take care of ourselves, we can't help other people. And in the words of my good friend John Southworth, don't forget about monitoring, monitoring, monitoring. Because this is a long-term game. There's no quick fix to this. God bless you all.
Man, thank you so much, Mike. I really appreciate you coming on the show, being a part of this, and just sharing with others. I can't thank you enough. Just wanted to go over a couple of things. I want to thank our sponsors again, Southworth Associates and Dreamscape Marketing, for really allowing us to do this. They provide us the time and the platform to be able to share great guests and mentors like Mike Walsh with you guys. Also, for any of your monitoring needs, I know we talked a lot about that. The Southworth Associates has really done that for years, and it's a vital part especially for these professionals that we're working with to provide that structured ethical monitoring to support their recovery. So definitely reach out to us at southworthassociates.net. We'd love to talk with you about that. And for any of your marketing needs, you can reach out to Dreamscape Marketing. And for any of your virtual trade show, conferences, events, definitely give me a shout. My cell number is 985-502-2849. And I would love to talk with you about that. So with that, we'll go ahead and close the show for today. Please tune in next.
Glenn, can I do a burning desire? If you're in this field or interested, go see programs. You cannot ever see enough programs, because that's the only way you're going to know whether it's a solid program or not. Go visit them, go talk to people. There's so much good out there, and we need more of it. Thanks.
Absolutely. Absolutely. All right. So guys, tune in next week, Wednesday at 1 Eastern or 10 Pacific. My guest is going to be Dr. Leah Claire Bennett. She's the Director of Operations and Professionals Programs for Pine Grove. So we're really excited to have her on. And with that, we'll go ahead and close today. Thank you guys for joining us, and we'll see y'all next week.
Thanks, Glenn.
Thanks, man. I appreciate it.